today I'm going to talk about the ADA guidelines for basal insulin optimization, which is a foundation for better glycemic control. So now the ADA 2026 has given a press release for the professional practice committee, and how do we approach our patients who needs insulin therapy. Patient-centric approach is important, so which has to be individualized, evidence-based diabetes management strategy, and also we have to incorporate the technologies which what we have now. So that we have a technology like the monitoring device, ambulatory glucose profile, which is a 24 hours CGM data. So we can how do we incorporate in the management of diabetes. Why the basal insulin optimization matters. So the basal insulin, which can even provide 30 to 50% of the daily insulin needs in diabetic populations. It's serving as a foundation for metabolic stability. So once you control the fasting sugar by increasing the basal insulin or providing the basal insulin and fix the fasting first, then you can able to bring down the postprandial controls. So that's why that's a very important foundation for metabolic stability or the basal insulins, which also gives a glycemic stability. So the stable fasting sugar, and it can even provides the overall glycemic control throughout day and night. So the long-term protection from micro and macrovascular complications with the basal insulins, which also enhances the quality of life of our patients. So the physiology of basal insulin secretion. So if you take any time, even in the patient is in the fasting state, there's a slight amount of basal insulin secretion you can able to see. So even in healthy individuals, the basal insulin secretion, which provides continuous manner, the low level of supply that maintains the fasting sugar homeostasis. Let's see, when the patient has a good amount of hepatic glucose output, that has been addressed by basal insulin secretion throughout the day and night. So the basal insulin accounts for around 50% of the insulin needs for adults and also around 30% of the pediatric basal needs for creating the metabolic foundation for glucose control. So the basal insulin journey from the past to present, we had a NPH insulin for decades. We have used, now we are also using for certain patients' profiles. Now we have long-acting insulins, which is a basal insulin, and ultra long-acting insulin is the second generation of basal insulins. So the pharmacological innovations have transformed basal insulin from unpredictable intermediate-acting insulins because of the hypoglycemic events are significantly higher for NPH insulin because of the peak insulin absorption at around 6 to 7 hours after the injection of NPH insulin. So the basal insulin is advanced insulin. Then we have a ultra long-acting basal insulin analogs, which is a second generation of basal insulin with a peakless action, a flat profile, where there is an incidence of hypoglycemic events are significantly less. And also this second generation of basal insulin and the basal insulins can closely mimic the physiological secretion patterns. So what about the starting dose? How do we initiate basal insulin as per the ADA guidelines? We can start with the 10 units of basal insulin at bedtime or even in the morning, or you can start 0.1 to 0.2 units of basal insulin per kg per day based on the body weight of the patients. If the A1C is around less than 9%, we can start with the 0.1 to 0.2 units. If the patient A1C is more than 10% or even 11-12%, then we can even increase to 0.3 or even 0.4 units per kg body weight. So that's the starting dose. How do we adjust the insulin dose? Around 10 to 15% of the insulin dose can be adjusted based on the twice weekly FPG response, or even 2 to 4 units of insulin can be adjusted. If the patient has the FPG target biweekly SMBG, then we can even continue the same dose. If the biweekly FPG values are higher, then we can increase by 10 to 15% or even 2 to 4 units. So the range you have to maintain, the fasting range should be between 80 to 130 for optimal metabolic control. The clinical inertia is one of the main barriers for the physician's point of view for achieving the better glycemic control. The common barriers, the patient fear of needles and injections. Hypoglycemia is the main concern for injectables from both patients and also from providers. And the complexity of the regimen is also one of the common barrier in the management of diabetes. The emotional resistance, psychological factors also plays a role. So our responsibility as a primary care providers and diabetic educators, we have to play a crucial role in early initiation and systematic titration. The patient empowerment through the education, shared decision making significantly improves the acceptance of the therapy and adherence of the therapy. Self-titration protocols. Now you can even see there's an app you can able to download the dose check app. The app works based on the FPG values. When you install the app and you just enter the FPG values on the 5th, 6th, and 7th day of the injections, then the app will calculate the next week basal insulin dose based on the FPG values. It takes the average of 5th, 6th, and 7th day of values, and it also predicts how much insulin, the basal insulin, has to be given for the next week. It gives you an idea. So the dose check app is based on the FPG values. The self-titration is very important. Before the patient comes to a doctor, if they can able to understand how they can able to do the self-titration and bring down the FPG, then they eventually they can able to bring down the PPG as well, and the HbA1c control can be easily achieved. So structured patient-led adjustment with a small incremental dose, like a 10 to 15% of the insulin dose, or even 2 to 4 units of insulin, based on the clear guidelines, can be given. So the algorithm guided adjustment. So every 3 to 7 days, based on the FPG values, you can even have a simple decision of dose change. Regular communication is important between the patients and care teams, which optimizes the outcomes and safety. So the systematic titration approach, the evidence-based algorithms, provides clear pathways for dose adjustment, empowering patients while maintaining safety guardrails and clinical outsides. For example, in the right side, the picture is given. So if the fasting sugar is 130, then we can increase the insulin dose by 2 units every 3 days. Then check for FPG response. If the FPG is above the target, again, we can increase the insulin dose by 2 to 4 units. Then every 3 days, you can check the FPG values and you can even do the adjustments. If you have achieved the FPG target, you can maintain the same dose. This is how that we have to explain to our patients and educate our patients. Definitely, that's a personalized insulin therapy, moving beyond one size fits all. So one size doesn't fit all. So we have to move beyond this statement. So the personalized insulin therapy is needed for all our patients. So the comprehensive assessment, we need to consider the age of the patient, diabetic duration is very important. Any newly diagnosed diabetic patients, they respond better with the insulin therapy, but the long-term diabetic patients with the multiple OAD for more than years, they may not respond to the insulin therapy. The starting dose has to be a little higher than the recommendation, like the 0.1 units per kg body weight may not respond to the patient. Why we need to start the basal insulin? Why not the prandial insulin? Why not the premix insulin? Why not the co-formulations? Because, the average insulin initiation, average HbA1c for Indian patients where we initiate insulin is around 8.5 to 9%. So till 8.5 to 9%, we try to maximize the OAD for our patients. So when the maximum OAD has been achieved, more than 3 OADs or 4 OADs, still the patient is having challenges of keeping the A1C under control with the HbA1c of 8.5%. Then only we think about insulin initiation to our patients. So what happens when you start insulin to our patients with the HbA1c of 8.5 or 9%? The fasting contribution is significantly higher than the PPG contribution. So that's why the basal insulin response is much better when you start insulin to our patients after the OAD failures. So the fasting insulin sugar has to be controlled only with the basal insulin. So that's why when you start insulin to our patients, start with the basal insulin, not with the prandial or co-formulations. So the target customization based on the patient's response, based on the age of the patient, based on the comorbidities, based on the personal health goals, we can have the customized target. The safety is very important. The first safety, reducing the hypoglycemia episodes, which can improve the patient's confidence. Early timely initiation of basal insulin. So the more you delay, the more the risk of diabetic complications. So we need to have a prompt action. So the benefit of prompt action, like start basal insulin earlier when the oral agents fails to maintain the adequate glycemic control. So when you have a 3 OADs, still the patient is suffering, struggling to get the HbA1c under control, then that's the time where you should talk about basal insulin therapy. If the patient says okay, then we can start immediately with the 0.2 or 0.3 units per kg body weight. By starting the insulin early, we can reduce the diabetic complications and preserve the remaining beta cell functions. We can even address the insulin stigma by normalizing its use as a part of comprehensive care and proactive care. So prevents prolonged hyperglycemia exposure and also associated tissue damage if you start insulin early. So the clinical evidence is also shows that early intervention can lead to success in the management of diabetes by initiating early insulin therapy in a landmark 2025 study that shows impressive A1C response up to 1.2% over 6 months of period, which demonstrate the powerful impact of timely intervention on metabolic outcomes and sets a strong foundation for long-term glycemic control. So clinical outcomes and real-world evidence also shows that improvement in the HbA1c by 0.7% if we can able to early intervene by insulin therapy. And also the reduction of HbA1c. Apart from that, there's improvement in the time in range by 15% by CGM data. So the CGM technology, it shows there's improvement in the time in range, and there's a reduction of hypoglycemic events by 40%. Particularly, the nocturnal hypoglycemic events are decreased when they use the CGM data and adjust the insulin dose accordingly. So the patient-centered benefits, treatment satisfaction, first important. So they increase the confidence and satisfaction with the diabetes management leads to improve the quality of life and reducing the diabetes distress. And it can reduce the fear of failure. The advanced monitoring device, like I said, the CGM Libre 2 Plus is the advanced one, which can able to predict the hypoglycemic events and hyperglycemic events. It gives an alarm in your phone, so you can able to see and you can able to react to that. So which can predict alerts, significantly decrease the anxiety around the hypoglycemia, particularly overnight. So better adherence to the treatment when you use this CGM data. So simplified regimen with the smart technology support leads to improvement in the medication adherence and fewer emergency visits. Health system implications. The cost saving because of the recurrent hospitalization, hospital admissions, and which can also reduce the complications of diabetes and delay the chronic disease progression, generates substantial healthcare cost savings over time. And quality importance, improved performance on the diabetes quality measures, including A1C control, hypoglycemic rates, and patient satisfaction scores. Of course, team-based care, the multidisciplinary diabetes team, including the endocrinologist, diabetologist, educators, pharmacists, primary care providers, and also the providers can optimize the outcomes. So, practical recommendations for doctors, clinicians, actionable strategies for implementing evidence-based basal insulin management. Early initiation of insulin, particularly the basal insulin at 10 units in a day or 0.1 to 0.2 units per kg body weight. Structured titration based on the FPG response, we can even titrate. Technology integration, like the digital tools to personalize the therapy and achieve the superior outcomes, and a team collaboration within multidisciplinary team to overcome the barriers and address the clinical inertia. Empowering the patients in basal insulin therapy, comprehensive education, which provides clear instruction on insulin, action profiles, which insulin has to be given in the morning, which insulin has to be given in the night. In terms of in the condition of hypoglycemia, which insulin dose has to be decreased. So clear instruction has to be given to our patients. How do we recognize hypoglycemia? How do we prevent the hypoglycemia? With the proper self-monitoring technologies, we can even educate our patients, encourage adoption of CGM, the smart insulin delivering devices, particularly the insulin pump. Any patients who have a huge fluctuations in the blood sugar values, particularly the type 1 diabetic patients. Patients with the brittle diabetes, we can even suggest for the insulin pump. Very few good options of pumps are available in the market. So 780G is one of the advanced pump through which you can able to avoid hypoglycemic events. So the time in range, you can able to increase by 780G pump. So as per the guidelines, if any patient with the type 1, younger people or even the type 2 diabetic patients, the time in range should be more than 70%. By using the 780G pump, the patient can be able to achieve the time in range beyond 90%. And also the time above range and time below range has been addressed with the advanced 780G pumps. So we need to also address the barriers, actively identify and address the emotional, psychological, practical barriers to insulin acceptance and long-term adherence. Clinical strategies of basal insulin optimization in our practice. Again, the starting dose is around 10 units or 0.1 to 0.2 units per kg body weight, which can minimize the hypoglycemic risk. Gradual titration every week Instead of going for third week of fasting sugar and adjusting the dose, I do in my practice every week FPG response. Then after the FPG response, we can even modify the insulin treatment. And regular assessment is also important, which can prevent the hypoglycemic events and minimize the weight gain and optimize the control. How do we combine basal insulins with other therapies? Of course, GLP-1 receptor agonists can be safely combined with the insulin therapy. Now, in fact, we are expecting the once weekly basal insulin icodec. Now we'll be expecting the semaglutide with icodec in the name of icosema. So that's once weekly GLP-1 RA with the once weekly basal insulin will be available in another 2 to 3 years in India. So, so the basal insulin can be safely combined with the GLP-1 RA. Now, the lixisenatide is also the combination of insulin glargine with the lixisenatide is also available, which can have both FPG control and also the PPG control. So we can combine the GLP-1 medications to reduce the total insulin dose requirements while improving the weight management outcomes. So, of course, you have a fear that after the insulin initiation, because insulin is considered as an anabolic hormone, the weight may go up. So, adding a GLP-1 RA along with the basal insulin or the prandial insulins can be able to manage body weight. SGLT inhibitors can also safely be given in our patients with the basal insulins. The advantage of giving basal insulin along with the SGLT inhibitors, any patients with the euglycemic ketoacidosis, the insulin can be able to prevent the ketosis formation. So safely we can add insulin to patients with the SGLT inhibitors. Comprehensive protection, as per the 2026 ADA, strongly supports combination therapy approaches for superior glycemic control and multi-organ protections. What about the special populations, like elderly people and the pediatric populations and people in childbearing age? The basal insulin can safely given in people with the pregnancy, GTM. The precise dose adjustment is definitely needed because the insulin throughout the pregnancy to prevent the maternal hypoglycemia, we have to carefully titrate the insulin dose while avoiding the fetal complications. Enhanced monitoring by CGM is strongly recommended for real-time glucose tracking and pattern recognitions. Then we can able to adjust the insulin dose. The trimester-specific care adjusts insulin requirements as they change across the pregnancy stages during postpartum period. Elderly patients, safe insulin is the basal insulin to be started for the elderly patients. And patients with those with the kidney and heart disease, then we have to be cautious about basal insulins. So we have to relax the glucose target. Even the time in range has been relaxed to 50% for people with the CKD and type 1 diabetes and elderly populations. The frail people who has a tendency of fall, hypoglycemic unawareness people, the time in range target is around 50%. So the relaxed glucose targets can be given for these patients. So the lenient fasting glucose target of around 100 to 150 to minimize the dangerous risk of hypoglycemia in our vulnerable patients. So organ function consideration, make careful dose adjustment accounting for reduced kidney function because the risk of hypoglycemia, particularly the long-acting insulins, the basal insulins is significantly higher for people with the CKD stage 4 and 5. So we have to prefer using prandial insulins if the sugar goes up. Usually the patient with the CKD is 5 and the patient is going for hemodialysis in stage kidney disease. The diabetes gets controlled because we call it as a burnt out diabetes. So there's no need for insulin treatment for these people. Because of the altered insulin clearance, there's no need for insulin treatment. If at all they require insulin, you can go for small dose of prandial insulins. Simplified regimens prioritize ease of use, safety over aggressive glycemic targets to reduce the treatment burden to improve the adherence. Hospitalized critically ill patients, the basal insulin remains the cornerstone, the foundation of glycemic control in hospital and ICU settings. Implement the intensive glucose monitoring protocols with a regular assessment. Rapid dose modification is essential as a clinical status and nutritional intake change. Team coordination with the multidisciplinary approach ensures optimal management during the critical illness. How do you overcome the barriers? Enhancing the patient's engagement, building the confidence and understanding about the insulin. We can address the insulin stigma and fear. So we can provide the comprehensive education on basal insulin benefits safety profile, mechanism of action to our patients. We need a diabetes educator, nurses. We can even empower the patients with modern technology tools, personalized management plans that fit into their lifestyle. Share success stories. That's also I do. Connect patients with the peer support communities. Address common myths, misconceptions about the insulin therapy. Insulin is not the end stage. We can even treat glucotoxicity or lipotoxicity with the short-term insulins. Once you bring down the HbA1c under control, if there's an improvement in the beta cell function, then we can slowly wean off the insulin. So that confidence we have to give to our patients. We need to emphasize insulin as a powerful tool for health, not a sign of failure. So we have a role as a healthcare providers. The collaborative decision making, engage our patients as the partners in the care through shared goal setting and mutual respect for preferences and concerns. Telemedicine integration, we often do the telemedications, teleconsultations we do, data-driven guidance. We need to utilize the CGM data, digital tools to provide the personalized recommendation based on the individual glucose patterns, and continuous education can provide ongoing training and resources to ensure the patients feel confident managing their therapy independently. So I conclude that the building the foundation for better outcomes empowered by the evidence. So we have 2026 ADA guidelines to provide the robust framework for personalized technology-enabled basal insulin optimization that transforms patients' care. The three pillars of success is early initiation, individualized dosing, and continuous monitoring for foundation for safe and effective glycemic control. So together, these advances establish an elevated standard of care that prioritizes both clinical outcomes and patient experience. So we have Sustaglar in India, which is a clinically proven insulin glargine, which has 100 IU in ml. A robust phase 3 trial was conducted in India to evaluate the efficacy of Sustaglar and safety immunogenicity of Sustaglar as compared to the reference innovator insulin glargine. So the A1C reduction, FPG, and immunogenicity was assessed. It is almost similar as for the reference innovator glargine. So they have done study with the type 1 and type 2 diabetic patients. So the endpoints of the study, the non-inferiority of A1C reduction, the comparable fasting sugar control, similar incidence of hypoglycemic events, and no significant difference in the anti-insulin antibody formations. So Regenix commitments, changing diabetic history. The Regenix, they have a commitment with the Sustaglar and future biosimilars extends beyond the glycemic control to fundamentally changing the natural history of diabetes through innovations, quality, outcomes, access, and future of developing next generation of biosimilars. So that was my last slide. Thank you for your time.